And I want to warmly welcome everyone who made time to join us here today at the University of Southern Denmark in Odense. And it is a great pleasure for me to introduce Sandra, our guest today. My name is Anita Wohlmann. I'm Associate Professor of Anglophone Literature here at the University in Southern Denmark. And the context of this talk is that here at the University of Southern Denmark, we have a great focus on narrative medicine, both in teaching and in education. So together with my colleague, Cindy Morgar, who is also here in the room, we are coordinating the narrative medicine course at the medical school here in Odense. And this is a mandatory course. And we're very proud to be able to offer this course here in Denmark. We regularly invite speakers and guests to speak with us and also to our students. This year we have the pleasure of having Sandra Apondo from the Technical University in Munich joining us. Sandra, and this is now the part where I try to introduce her very incredible CV. Sandra studied medicine, history, and Slavic studies at the University of Heidelberg in Germany. She has a master in health business administration, and she recently completed a master in medical education. She also wrote a PhD, so she is also a doctor in that sense. And the PhD was on doctor-patient communication and how insights from research can be implemented in medical education. In her medical career, she then specialized in psychiatry and psychotherapy, and she worked for 10 years at the University Hospital of Heidelberg in the division of general psychiatry. She's also very much involved in the Association of Patient Experts, and she works as a trainer for patient experts. In addition, her research interests are, among others, professional identity formation and medical education, patient involvement in teaching and research, stigmatization in medical professions, and more generally, qualitative methods in researching learning processes. In 2023, Sandra decided to leave medical practice, and she joined colleagues in Munich at the Technical University in Munich, where she's now the chair of the team lead. It's great to have the person correcting me sitting right next to me. So she is the team leader of curriculum development at the chair of medical didactics, which is held by Professor Dr. Pascal Berbera. It is my great pleasure that Sandra accepted our invitation to visit us here in Odense and to speak about a topic that is both very personal, but also very relevant beyond Sandra's individual experiences. Before I hand over to Sandra, just two pieces of housekeeping. We agreed that Sandra would speak for about 45 minutes today. And after that, we will have a discussion, an open discussion. And you're very, very welcome to ask questions either through the chat, and you're very welcome also to write those questions while Sandra is speaking. She explicitly told me to say that. And then, of course, after the discussion, I will facilitate the discussion, and you're very welcome to either ask questions by raising your digital hand, or I will read your questions from the chat. And with these words, I hand over to Sandra and look very much forward to your talk.
Yeah, thanks so much, Anita. It's a great pleasure to be here. I can see we have participants from all over Europe, from Germany, from Switzerland, from the UK, I think. Thank you all for taking your time and being here. Okay, before I start, this is going to be a personal talk about my cancer experience. So I share my personal experience with my illness, but at the same time, I combine it with what I read in books, especially in illness narratives, what I talked about with many other cancer survivors, and what I know by, well, knowing the literature in medical education as far as patient involvement and also narrative medicine is concerned. And I also speak from my own experience as medical teacher and curriculum developer. So just to give you an overview of what I want to talk about today. So I want to talk about patient-doctor relationship and my experiences of being either the doctor or the patient or both at the same time. I want to talk about the emotions of illness experience, vulnerability of us as human beings. I want to talk about how ill people tell their stories, how they search for language, and I will present different narrative types and share some thoughts on the value of using stories of people with lived illness experience in medical education. So during this talk, I will switch perspectives multiple times. It might be a little bit confusing for you sometimes from which perspective exactly I'm talking, but that's basically the whole point, because it is confusing, because my roles, they are a bit mixed up now. So the roles as a patient, a doctor, and a medical educator. So for the next 45 minutes, I invite you to join me to look at these topics from all these different angles and changing perspectives with me several times. And I'm also looking forward to your questions and the discussion that we can have later on. Okay, so let us start with the first perspective. That's the one of how a medical professional, I would say, also I as a doctor myself, can look at my own illness. Yeah. So this is how my patient case goes. Yeah. How I was presented in morning rounds, in ward rounds at the hospital. So I was 35. I had no past medical history, was increasing back pain for several weeks, a persistent dry cough, shortness of breath, severe chest pain, numbness and pain in my left arm, and a mild fever on and off. So the shortness of breath led to an MRI, which then revealed a primary mediastinal large B-cell lymphoma, short PMBCL, so an aggressive type of non-Hodgkin's lymphoma. The state-of-the-art therapy consists of a combination of immunochemotherapy, so a lot of drugs here. They're called etoposide, vincristine, cyclophosphamide, doxorubicin, plus prednisone and rituximab. So all the good old chemo drugs were used, dose adjusted. So that means that the doctors try to increase the dosage by 20% each cycle, depending on the side effects. So this was one of the about 28 liters of chemo that I received. In case you're wondering why it's orange because of the doxorubicin that's inside there, which has a very, very ugly, bright red color, and therefore is known as the red devil. Is also in there, but it's mixed with the other transparent drugs. So that makes the whole thing orange. Then I had a final PET-CT after about 5 months, and there was complete metabolic remission, so no signs of cancer. And that's it. Yeah, so end of story. And I could end like this, basically, yeah, because it's a story of success, and that is what my doctors told me in the beginning. They said, you will be fine. Yeah, it's an aggressive tumor, but we have more aggressive chemo against it. And consider yourself lucky. You have this type of non-Hodgkin's lymphoma and not another. And yours is highly curable with good long-term survival rates. Yeah, you will be fine. That was the key message. And I am fine. And I do consider myself lucky. but definitely not because I won the tumor lottery with my PMBCL. There's, by the way, no such thing. This is something doctors like to say. There's a tumor lottery. I've never heard a cancer survivor say that because every cancer is kind of shitty, but that's a different topic. So, but I do consider myself lucky, but for different reasons. So let me give you another side of the same story. So the story or the perspective of a sick person. So I entered Cancerland after being sick for about 2 months. So first, I didn't pay much attention to it. It was winter 2021. My kids had running noses all the time, and I was sick on and off. Yeah, a bit of a common cold, a bit of a cough that didn't get any better. And suddenly, the symptoms became really bad, real quick. I got a fever and severe cough day and night, and I couldn't finish a sentence without coughing. I still went to work. I mean, it was in the midst of the COVID pandemic. We were tested for COVID anyway, every day. So, but it wasn't COVID. So I thought, okay, it's going to be fine. My back and my shoulders were hurting. I got physio. The physio didn't help. The pain increased and moved to my chest. And within a week, it got so severe that I couldn't get through the day without a lot of painkillers, and even some light opioids at that point didn't help. So when I had difficulties breathing, I was sent to get an MRI. So I want to take you now to that first MRI. So it took place in the hospital where I worked at that time, at the University Hospital of Heidelberg, where I worked as a psychiatrist. So I was in the MRI for about 50 minutes. Because they scanned my whole body. And I don't exactly remember whether I was scared or what I felt. I was so focused on trying not to cough and to follow the breathing orders, which was really hard enough. So I thought, okay, I come out and they tell me I maybe have some sort of pneumonia, or I simply have nothing. Yeah, that explains my symptoms. So I came out of the MRI, and there was the senior radiology consultant. She was right there, and she had a very serious look on her face, and she took us to her office and basically showed us pretty much these two images. So what do you see? I'm sure there are medical doctors here. Does anyone want to say something? Or is this a normal MRI? No, probably not. Okay, so this, yeah, this doesn't belong there. Okay, so maybe if you look at this like from a professional perspective, you might think, okay, this looks suspiciously malignant. It's large, 10 times 8 centimeters, but let's not jump to conclusions. Yeah, we do a biopsy first, and then we'll see. But I didn't look at it as a doctor. The way I looked at my own scan was as a mother, and as a mother only. And my children were then 2 and 5 years old. So what I asked the radiologist was this: what will happen to my children? And in my head, the question continued like this, but I didn't dare to speak that out loud. But it went like this: what will happen to my children when I'm gone? And that meant not gone for a few weeks, being admitted in a hospital. No, gone meant, yeah, being gone for good, yeah, being dead. So, and many authors and patients have described this very first moment when they got the bad news, yeah, when they realized, I have just reached a point in my life that divides my life in two. Yeah, I had a healthy one that has just ended now, and a sick one has already begun. I had a life with a job, and now I'm probably not going to be able to work again. Or I had a life with a future and plans, and now a life where only the present counts. So simply put, one life without cancer and one with cancer. Because you cannot think of the life after cancer yet. But what you do think about, even at this point in the beginning, is that this is how your life with cancer can end. And that this moment can actually be the beginning of the end. And it's a shocking moment, which is very difficult to describe. Some people describe it as a fall, like a fall into a hole, into a big nothing. So I also fell. So the radiologist's job was to break the bad news to me. And I can't remember what she said exactly. I think she left my question about what will happen to the children unanswered. But she gave me space to feel whatever I was feeling then, this feeling of shock. So she was just there. And she came close to me, she touched my arm gently, and she looked really sad. And she didn't hide it. And she was the first doctor who showed me that showing one's own vulnerability as a doctor can be immensely helpful for the patient. So what she taught me was, give your patients space for whatever they are feeling. They don't know what they're feeling yet. Just give them some form of space. And maybe if you do not know what to say, maybe just say nothing. Just say nothing and just show that you're there. That's what she did. So the next day, I met with my GP again, and she showed me her vulnerability too. And I want to add, I didn't have a long relationship with her. I was never really sick before. Maybe I saw her 5 times for vaccinations or antibiotics or something, yeah? So it was the following morning after the MRI. And now I was the one breaking the bad news to her, so to speak. So I said quite unemotionally and still under shock, I simply described what that scan revealed in a medical language. So I have a 10 times 8 centimeter mass in my chest. It looks malignant. And what happened really surprised me. She cried, as in she didn't even try to hide her tears or wipe them away. She just cried. And she hugged me and she held me for a little while, which then made me cry. So we stood there for a while. It was probably just a few seconds. I don't remember what we talked afterwards because it really didn't matter. Yeah, because her behavior mattered and her honesty and her vulnerability. And I know physical touches and hugs amongst doctors and their patients, they should be viewed critically. But for me and for her, it was appropriate and it was healing. So it was a moment I can never forget. Just like there are so many unforgettable moments when it comes to the doctor-patient relationship. And when doctors say the most inappropriate and hurtful things to their patients, they often say it unintentionally, not knowing any better, not reflecting enough before they speak, but that happens. And these words are painful. But also the good and the kind gestures, they can last forever in a patient's life. And showing their vulnerability. So, and what being a patient here taught me, that our words as healthcare professionals, your words, whether you work with students as a medical teacher or you work with patients, your words and gestures, they matter so much more than you can imagine. I would even go as far as to say words can destroy people, but they can also really heal them. Yeah, so we changed perspectives again because there's another one. So now I was a cancer patient. And of course, I was still a mother. So I want to talk about that perspective. So my children, they're here. So on the left side, you see my daughter. She's 2. or she was 2, now she's 6, okay? And my son, who was at that time 5 years old. So my children didn't know or have heard of cancer before my diagnosis. Yeah, they never saw a cancer patient. They had no concept of it. Yeah, so cancer to them was a type of sea animal. Yeah, and the sign of the zodiac that comes before my son, who was born in August. So he's a lion. Yeah. So we explained to them that my sickness was called cancer and that it's a strange name. That it's a severe disease and that people can die from it. But that nowadays, the majority of people, if treated successfully, yeah, they survive and they get healthy. So we explained that I need strong medication through a catheter, which they really looked at with amazement and not with fear. And that this medication will help me, although it will give me other problems first. So one of the problems being the hair will fall out. So within 5 days of after my first chemo cycle, the hair fell out. And my children wanted to keep my hair, which was about this long at that time, tied to a ponytail in a little box in their nightstand. And it's actually still there up to today. So they wanted to keep the hair. And then the little hair that was left was shaved off. And the kids wanted to see how I looked. Because the first day I had covered my head with a cap, because first of all, I didn't want to see it myself. And second, and for a very simple reason, the head feels super cold and weird at the beginning. And although there is no hair anymore, the skin actually hurts. It's very uncomfortable. And a warm cap kind of reduces that pain a little. So when I removed the cap, my son covered his eyes. Yeah. And my daughter, she didn't do anything. She just looked at me. And what my son said was this: "You look like a robber." Now, why am I telling you this? Because it has something to do with language. And language has something to do with emotions and experience. So he said, like a robber. I myself wouldn't have used those words. I just thought I looked ugly. Yeah? But hearing him say it out loud showed me something that I actually felt. And it was true. I did feel like a robber and like being robbed of something, both at the same time. So my son's words got me thinking about this line, "You look like a robber." And I thought, yeah, because I'm being robbed of something. Yeah, of my health, my hair, integrity of my body, you name it. Joy, hope, time, 1,000 things, freedom. Sometimes it felt like, my whole self is kind of disappearing, taken away by something. And I don't even know that I would say taken away by the cancer or by the excruciating treatment of the chemo. So, but I was also the robber myself, just the way I looked. So why am I saying this? And this is a very important point to me, because I think that my lymphoma, so my PMBCL, is part of myself. Yeah, it belongs to me. It's a sick part, for sure, but it is still me. So the lymphoma is mine because it lives in my body and in my body only. Cancer cannot live by itself. Cancer is not an it. Yeah, it has no life. So the cancer cells are my cells in my body. So it is my body that is making my hair fall out and my face swollen and puffy from the steroids and my bone marrow depleted, and it's making me vomit and faint and sweat the whole night and all these things. Okay, so cancer is no it, yeah. And oncologists, they don't think like that. So they tell me, it's not true. Yeah, it's not you. It's the cancer. The cancer is doing this to you. The cancer is your enemy. We all fight against it. So, but what doctors don't get is this, that it doesn't work like that. I cannot separate my cancer from my body, from myself. The cancer is part of me. And how do you fight tooth and nail what you should do, against something that you have or against something that you are? So oncologists say, we fight against it together, So, and I, as a sick person, I ask myself, okay, first of all, who's we, or who are we, and who is it? What is it? And then I ask myself, okay, when we fight against it, the cancer, then who am I in all of this? Who am I as a sick person in all of this? And I mean, this question of who am I is a difficult question to answer in general. I mean, also when you're a healthy person, I mean, it's not easy to answer. But when you're severely ill, this becomes extremely difficult to answer. Okay, so it was so unexpected to me that my children themselves used this form of fighting language, And I'm sure you know this, the warfare metaphor is rampant in oncology, As a doctor or a patient, it's basically impossible to avoid it. So halfway through the chemo, I started fighting this fighting language, so to speak, trying to find a language that felt more adequate and precise to me. So looking for a different language to me also means reading what other ill people have to say. And there's a great book that I highly recommend by Nina Riggs, The Bright Hour. She had breast cancer. She died of breast cancer at the age of 39. And in these 300 pages, she not only once uses that warfare metaphor, and this, we fight against it. And it's such a relief and pleasure to read that book. So I just want to show you one passage because she also likes writing about the bald head. So I found a quote in that book, and she's saying, I hated it. But as my head began to resprout, I also note that baldness served a role, like mourning clothes. I am going through something, it announces. Be gentle with me. I miss my bald head, emails my high school friend Christy, who also did chemo this year. She's a couple of months ahead of me in her treatment. That is one very complicated emotion, I reply. And that's it. And she doesn't explain it. She doesn't say what is complicated about it. She just leaves the reader with that. And it is complicated on so many levels. And for me, writing is one way to shed lights on these complicated emotions. So the search for language is a search for understanding one's own emotions, especially the ones I didn't have words for whilst being ill. All right, there's another change of perspective. Now, I was out of Cancerland. I was healthy, and I was a doctor again. So I went back to the psychiatric hospital to work. After a year, I came back with super short hair. And for me, it was the most natural thing to do to just tell my patients, my psychiatric patients at that time, that I had cancer. And they all really, with no exception, they responded with an appreciation and honesty and without any pity that really amazed me. And it's a form of empathy that I only found amongst people with lived illness experience. And it was a relief to talk to them. And up to today, to speak to someone, especially with cancer experience, relaxes me. I can relax completely. Because there are many words we do not use because we don't need the words to explain how cancer feels or how certain symptoms feel like. Just know it. And that saves a lot of energy that we need for more important things, yeah, for real emotionally supportive conversations and for just being there for each other. So whenever I thought it might be helpful for new patients that I saw in the psychiatric hospital, I shared my own experience briefly. So like I did with a young woman who actually had non-Hodgkin's lymphoma, the same kind as mine, which is rare. And she was undergoing the same kind of chemo. And she needed a phone appointment because she was too weak to come in, because she had difficulty sleeping. And so thoughts kept her awake at night, thoughts of giving up chemo, of not being strong enough to survive the hell she was in. And yeah. So I prescribed her sleep medication, but I also realized that I had to share with her that we, in fact, share the exact same diagnosis. So, and then, of course, the conversation changed, because then we talked like cancer patients talk about whatever comes up, of chemo-induced dull headache, brain fog, you name it. Yeah, little things like that. And a week later, I saw her. She came to my office and she said that she was feeling better. And then she said really the nicest thing. So she said, yeah, I'm feeling better because you two are still alive. And it was such a beautiful moment because I simply gave her hope by being alive. There was nothing else that I did. So, but she gave me hope too. And she went into remission with first-line chemo, just like I did. And I was super happy. But unlike me, she had a recurrence within 6 months, and early recurrences come with bad prognosis. So I never find out how she is today. She might be in stable remission. She might have died. And that is one of the central parts of being a cancer survivor too. Yeah, you survive, you live like others survive until one day they don't. Yeah. And they go into that last phase, yeah, of the cancer journey. Okay. So now my journey in search for language began. So I wanted to find words for my experience, but I wasn't happy with the language that was offered to me through various cancer self-help books, blogs, movies. And I wanted to find an alternative language to this language of triumph and success and warfare and ammunition. And I'm just showing you a few. These are all, you know, front covers of important magazines. Yeah, war against cancer, how to cure cancer. Yeah, it's war and cancer everywhere. So I don't like that. So I wanted to read something else and see something else. So Arthur Frank, who himself is a cancer survivor for now more than 30 years. He had cancer when he was pretty much my age, I think, in his late 30s. So he examined the typology of narrative of illness very precisely in his book, The Wounded Storyteller. So he describes 3 different narrative types, which he calls the restitution, the chaos, and the quest narrative. So all 3 narrative types are told alternatively and repeatedly. So at some point during an illness, one narrative may guide the story. Often the restitution narrative dominates in stories of people who have recently been ill. I also used the restitution narrative in my first publications without really knowing it by that time. It was the natural thing to do. So I wrote and I spoke publicly about my cancer experience. I wrote articles about it, and mainly about this change of perspective. Yeah, so this particular journey from being a doctor to being a patient, and then going back being a doctor. So this is a story, a type of story people like to read. So why is that? Yeah, it's because it has a good storyline and because it's predictable. it gives hope, and it shows that even if something bad happens, something interesting can come from it, and that it all can end well. And we all like happy endings. Yeah. So I want to say a few things about the different narrative types. So the first one is called the restitution narrative. Or you can also say the triumph narrative. So the storyline of the restitution narrative goes like this. I was healthy, then I was sick, I was treated successfully, and now I'm healthy again. Yeah. Happy ending could be the person is healthy again, and often he or she becomes a better person. Yeah, somehow changed by the experience. But another not so happy ending could be the person dies, but that also could be framed in a restitution narrative as an heroic death, for example. Yeah. So either way, it's some kind of superhero story. Yeah, like here, kicking cancer's butt. What is your superpower? So in 2001, Barbara Ehrenreich, who was a breast cancer survivor at that time, she has criticized exactly this triumphant way of storytelling in her article, Welcome to Cancerland. A mammogram leads to a cult of pink kitsch. And she didn't find this narrow way of storytelling helpful for her own experience. So a quote from her article that sums it up really well, I think, is this one. Let me die of anything but the suffocation of the sticky pink sentiment embodied in that teddy bear. In 2019, the author Anne Boyer won the Pulitzer Prize for her book, The Undying. Please read that one too. It's also a good book. So she also had breast cancer, and she also criticizes this one-sided triumph narrative. And she says, to tell the story of one's own breast cancer is supposed to be to tell a story of surviving via neoliberal self-management. The narrative is of the atomized individual done right, self-examined and mammogrammed, of disease cured with compliance, 5K runs, organic green smoothies, and positive thought. Okay. The next narrative type is the chaos narrative. So the chaos narrative is not actually a narrative because it is so chaotic. So it has no storyline. It doesn't really have like this storyline of past, present, and future that a story requires. Because when an ill person is in complete distress, in pain, yeah, is overwhelmed by symptoms, the person can be speechless, yeah, because you cannot describe something that you have not experienced before, yeah, the intensity of the pain or the insidiousness of the nausea and the fatigue or whatever it is, yeah, you just lack words to describe it. So the chaos narrative is not really a narrative, but the chaos is something that you have to live and to live through, and that you can't tell it literally. You can tell it afterwards, yeah, but not really in that moment, because to tell a story also requires some form of distance and of self-reflection, and that is simply not possible during this phase of chaos. Like the distance that I have now allows me to speak to you. If I had an MRI scan in 2 days, I would not be able to talk to you today because the 48 hours before an MRI are just completely terrible. Yeah, and there's chaos only and anxiety and everything. And I cannot self-reflect about that. I cannot distance myself from that. Okay, so I want to give you 2 examples of how the chaos narrative can sound. So Audre Lorde, she also had breast cancer, wrote in her cancer journals, I was very anxious to go home, but I found also, and couldn't admit at the time, that the very bland whiteness of the hospital, which I railed against and hated so, was also a kind of protection, a welcome insulation within which I could continue to non-feel. Eric Mannheimer is another example that I found. He published this book, 12 Patients. He was the medical director of Bellevue Hospital in New York, himself a throat cancer survivor. So one of the 12 stories in this book is his story. Actually, the third of the 12 stories is his own patient story. So what he writes is, I was numb. I had pulled into myself and was less communicative, less emotionally available at work and at home. Marina, that's his wife, would cook for us and read to me, but I wasn't present. My withdrawal would continue involuntarily, almost to a vanishing point. I dug into my work in arranging my treatments without giving much thought to the hard times to come. There was no psychological preparation possible at this point. It was happening too fast, just as well. So the chaos narrative is something that is like in between the lines. It's in the absence of words. Yeah? It's somewhere what Lord and Mannheimer here describe as numbness, as non-feel, as not being present. Okay, now the last narrative, and then we come to the end soon. So the last narrative is called the quest narrative. The example I found is Anatole Broyat's Intoxicated by My Illness. I love that title, Intoxicated by My Illness. So where he describes this complicated search, yeah, for language, for meaning of illness, for meaning of life in the face of death. So the quest narrative implies that there is something to search for, yeah, that there is something to gain from the illness experience, but not in a triumphant sense, but that illness is about personal growth, about development, about new beginnings, about meaning of life, basically. And to gain something doesn't have to mean to get back to health. It could mean being fully alive while being sick, or it could mean even being fully alive in the face of death. So his book is a real treasure chest for very witty and humorous and really great and profound quotes. So just a few of them. So he says, I wish my doctor could somehow repersonalize my illness for me. It would be more satisfying to me. It would allow me to feel that I owned my illness. Nobody wants an anonymous illness. So maybe this reminds you of what I said earlier about my lymphoma. Yeah, I want it to be mine. I want to own the illness. Nobody wants an anonymous illness. So Broyat too criticizes the warfare language in oncology and claims that there's more to illness, yeah, than fighting. But it's about how illness transfigures you. So that illness can actually change people's lives and people's identity. So what he says about the warfare language, he says, their books reminded me of dispatches of war correspondence. They tell the reader a lot about the waking life of the cancer patient, but not much about his daydreams or fantasies about how illness transfigures you. Or this sums it up quite well. To be ill is an odd mixture of pathos and bathos, comedy and terror, with intervals of surprise. So to me, cancer as an illness experience is exactly this. Yeah, it's full. I would call it. It's full of ambivalence and contradictions, and maybe that's the reason why I find it so interesting, and I never get bored thinking and writing about it. Okay. Now I started with the doctor-patient relationship, and I want to share a few more thoughts about this very complex form of relationship. So all these wounded storytellers I have talked about so far have also written about their relationship to their doctors. And often these relationships are relationships of power dynamics, yeah? Or of difficulties of not speaking the same language and therefore not understanding each other. And I too have experienced power dynamics in relationship with my doctors. And of course, doctors don't like admitting that, yeah, that they have power over patients, but they do. Of course they do. Yeah, our lives are in their hands. Yeah, we depend on them entirely. And it's really a challenge to reconcile the language of medicine with the language of the illness. And that has something to do with power, because the medical language is very powerful. So let me give you a few examples. So doctors usually like it when patients play an active role in their treatment. Yeah. So when they are active, but they don't have to be too dominant, but they should be active in this process of SDM, yeah, shared decision making. So, but as a cancer patient, despite your wish for participation, you might get to a point in your treatment where you will be forced into passivity. Yeah? That's when the symptoms take over, when the fatigue or the pain or the depression or whatever becomes so severe that you cannot get out of bed, not for days. So I didn't think something like this would happen to me because I was always very active and full of energy, but it happened to me too, many times actually, many hours and days and nights. So I couldn't get out of bed, not physically, but also not mentally, because at some point, all mental and physical energy goes into just breathing, yeah, lying still, waiting for relief of pain, of thoughts, whatever, yeah, trying not to be overwhelmed by anxiety. So in a nutshell, being a patient means you have to be exactly that first. You have to be patient, a patient with really, you need a lot of patience. So, yeah, let me show you what active and passive in this context meant to me in Cancerland. So fulfilling the role of an active but patient means knowing the rules in the hospital and adapting to the expectations of the people working in the hospital. So there are rules in the hospital you learn very quickly as a patient. There are several. I just give you one example. So, for example, you should be ready when the ward round comes. Although you can never know when it actually comes. It could come at 8 a.m. or at 11, or sometimes it doesn't even come in the morning. So, and when you are connected to an IV drip 24/7, you think twice when exactly it makes sense to go to the bathroom to clean yourself, which can feel like the biggest task of the day. So then the ward round comes. There are usually more people in the ward round than you thought are on the team. Usually there are one or two new faces you have not seen before, and unfortunately, they rarely introduce themselves or are introduced by the only person you as a patient talk to, which is the person who is up on the hierarchy ladder. So it's either the resident doctor or one of the consultants or the medical director, depending on the composition of the whole group of these people in white coats. So what I did as a patient is I pushed myself to look okayish. Yeah, I sat upright in bed. I held my head up, back straight, looking at the doctor. Yeah, so, and I always got compliments for that, by the way. Like they came in and they said, "Oh, you look so great today. Yeah, you look really good." And I hated that when they said that. Okay, anyway, so but what I did, I used the ward rounds also to communicate, yeah, with them, of course. And I talked to them about what they wanted to talk about. And they want to talk about, in medical language, yeah, what doctors like to talk about. They talk about the disease, yeah, and the treatment. Yeah, I didn't have any other language at that time, but I had the medical language, being a doctor myself. So I used that, like kind of like a replacement for the language that I didn't have yet. So we talked about chemo protocols and the recent study and the lab results, blah, blah, blah. So, and I had my laptop open and I had all my smart questions written there. And that's what doctors like. That's what I like as a doctor. Yeah? The smart patient who comes to the ward round prepared and well-informed and talking eloquently, grammatically correct sentences. Yeah. So what happened then was, first, I felt good, yeah, and professional and confident. And second, I felt I had control over the conversation because I realized how the doctors relaxed, how they talked and shared their knowledge, how they felt in control too, and how they liked our conversation. So they were friendly, they smiled. Sometimes they stuck around a little longer with me than with other patients. They looked me in the eye, and often the conversation switched to something a little personal. Someone made a joke or commented on the book I was reading. So it was a good conversation. But what happened afterwards, and this has happened several times, was I lost my straight position and fell into bed, weakened and empty, because all the energy I had to put into this show. And then I was drained. And I felt empty. And by that time, by the way, I didn't really know I was feeling empty. Or what I thought was I felt empty, but I didn't know that my feeling of emptiness was actually more of a combination of loneliness, sadness, and disappointment. Also anger, shame, maybe guilt. But I didn't have the words for that yet, for this complicated emotion. So I didn't know back then what I felt. I didn't have words for it, and I just covered myself with a blanket and waited until the next situation came that gave me some reason, to get up. And then this empty feeling kind of faded, without me really noticing. And I just went from one situation to the next. But some of that emptiness feeling has stayed with me until today. And these are the feelings, like invisible shadows, almost invisible shadows of the feelings. These are the ones I want to talk and write about today. And I feel a need to do it, not only for myself, but also to help other ill people speak and find their own words, and to help medical professionals understand what ill people really have to say. So they don't have to hide behind medical language and then feel unheard and unseen and misunderstood. Now, my last role as a medical educator, this is now the last perspective. So I think it won't surprise you that I believe patient involvement should play a much bigger role in medical education than it currently does. I don't have time anymore to get into these studies, but there's a vast literature on how narrative medicine or patient involvement might foster empathy for patients. But what I do know, and what I think is valuable for medical education is, and I want to put this very simply, just read. Read illness narratives for yourself, with your students, if you are a healthcare professional. Listen to what ill people have to say in podcasts, in blogs. Invite them to your class, but not as patients, but as people with a unique expertise, an expertise that you don't have. So the expertise of illness. And make yourself and your students, speak to them, share with them. Because listening to people open up about their illnesses can encourage us as healthcare professionals to also open up about our own vulnerabilities. And last but not least, just write, just take a pen every once in a while, and trust the authority of the writing hand. Just write about your own thoughts and emotions, your own vulnerabilities, and acknowledge them by self-reflecting. Because I think this is what we as healthcare professionals owe our patients, to be self-reflective and to be able to acknowledge that we are also vulnerable, and showing that from time to time. So, because I think also as doctors, especially as those working with patients who suffer from life-threatening illnesses, we can ask ourselves the same question that I asked myself as a patient. And that was the question of, when we all fight against the cancer, the disease, against this big it, then who am I in all of this? So I can also ask you, yeah, who are you as a doctor, as a healthcare professional, a student, a patient, a future patient in all of this? And maybe by reading and listening, speaking and writing, trying out different ways of using language to describe illness or to reflect about illness, you'll discover new words, yeah, new language, or realize that sometimes more is said when no words are used. I want to end with one last quote by Audre Lorde from her cancer journals. It's one of her most powerful lines that is often quoted. It's about speaking out of empowerment, of breaking the silence around cancer. So she says, I was going to die, if not sooner than later, whether or not I had ever spoken myself. My silences had not protected me. Your silences will not protect you. So she addresses the reader directly. Your silence will not protect you. But the line that resonates with me most comes actually after this one. And it so well describes this journey I'm still on through sickness and health, searching for language. And that question is, what are the words you do not have yet? Yeah. What do you need to say? Okay. Thank you.